and subsequently it's open to discussion for all.
Good morning, everyone. Today I am going to present a seminar on the topic History of Depression, moderated by Shobhit Garg sir. So, introduction to depression. So, it is major depressive disorder is reported to be the most common mood disorder. Mood disorder, unipolar depression. So, mood disorders can occur in a whole spectrum from mania to hypomania to cyclothymia, unipolar depression, and but out of all these, unipolar depression is by far the most common mood disorder. So it can either be a single episode or recurrent episodes. But what we need to clearly differentiate here, what separates us from the layman is whether the person is suffering from a clinical syndrome depression or whether it is just normal sadness, a grief reaction, or some adjustment. So depressive disorders can include major depression, persistent depressive disorder, or dysthymia. It can be a bipolar depression, vascular depression, or other specified depressive disorders. So all out of all these types of depression as this list is from DSM-5, the common feature of all these is presence of sad mood, empty or irritable, the feeling of emptiness, irritable mood accompanied by somatic and cognitive changes which significantly affect the individual's capacity to function. This is the most important part which differentiates the diagnosed patient of depression from some normal sadness. So even today we see the layman may not be able to differentiate between these two things, but in the ancient times, 2000 years ago from now, Hippocrates still knew that these were two different things. He gave the term melancholia, and he was able to separate it from normal sadness. He also hypothesized a temperamental reason for these disorders. He knew that some people, a certain group of people, were more predisposed to developing melancholia, and some people did not develop melancholia even when they had many stresses. In 460 to 367 BC, 2000 years ago from now, Hippocrates was still able to explain, even though that was a wrong concept, but he was still able to find some kind of a biochemical background to melancholia. He knew that this was not only a psychogenic illness, but there was also some organic component, some kind of organic component to it. But he mistakenly attributed it to some a black bile, and he described melancholia in which there was an increase in the black bile in the body as a state of aversion to food, despondency, sleeplessness, irritability, and restlessness. This is considered the earliest biochemical formulation for any mental disorder. He believed that the illness arose from a substrate of melancholic temperament. So this is a painting which was made in Hippocrates' time, 2000 years ago. And even here we can see that he is able to describe the person with melancholia. The person is having sad effect, no interest in activities outside what is happening around here. He has a downward looking gaze. So and we can see planet Saturn in the background, in the upper. In this painting, we can see planet Saturn in the background, in the upper left corner. So, and the darkness in the background. So, this is what was Hippocrates' description of melancholia. The painting personifies that under the influence of pattern Saturn, the spleen secretes black bile, which leads to darkening mood through its influence on the brain. So, and he also said that there was a substrate of somber melancholic temperament. The person already had a melancholic temperament. He was predisposed to depression, and under some external influences, even though what he said were wrong, but during that time he was still able to explain that some kind of external influences also affected the disease. So, first ever documented case of depression that he said was a woman of Thessos became morose because of justifiable grief and did not take to her bed, suffered from insomnia, loss of appetite, complaints of fears and talked much, showed despondency, talked at random and used foul language. Many intense and continuous pains, she leapt up and could not be restrained. So, there was this particular case, he described some sort of agitation, some sort of disorganized behavior, and uh, so it could be at that time a case of either some kind of negative symptom of schizophrenia or could be bipolar depression. He was not able to differentiate between them, but he was still able to document the first ever case of depression. 100 years later, Galen, he said that melancholia manifested in fear and depression, discontent with life, and hatred of all persons. He was the first person to say that this particular illness could get so severe that patient could develop psychotic features also. The word he uses is the animosity towards member of household, sometimes a desire to live and other times a longing for death. So what he said that the person could be suspicious that a plot is being hatched against him. These were the words used by Galen. Later on, the first time a person published a full text about melancholy was Anatomy of Melancholy by Robert Butler in 1621. This is the first English text entirely devoted to affective illness. It was a review of all the researches and hypotheses that in the previous 1500 years that Robert Butler could compile. So at that time, Robert Button, whatever he included in melancholy was what we today classify under many different things. We can what we consider somatoform disorder, hypochondriasis, everything he put together under one umbrella term melancholy. He described clueless melancholias, which were sadness without any particular cause. He at even at that time quoted a higher incidence in males, and he could some he also got some kind of an indication about seasonal affective disorder because in that text he described autumn as the season in which melancholia worsened. So if they even in that time people were aware that some kind of seasonal affective disorder exists and some bipolarity could exist in individuals. In that text, he named 6 unnatural things that could cause a person to develop melancholia, and that those things were diet, alcohol, biological rhythms, and perturbations includes by passions such as intense love. These were the things that he in that text that he attributed could cause melancholia. This is the cover of that the Anatomy of Melancholia, first ever text. In 1840, John Philip Esquerel, he until 1840, melancholia was described as an insanity. People with severe depression, with cognitive decline, disorganized behavior, they were put in the same category as other people, with many psychotic people, and anyone who they found was disorganized. They all grouped together at one place. But John Philip Esquerel, for the first time, he said that affective disorders are different from the psychotic disorders. He categorized, until then, it was a form of insanity, but he separated it from insanity and called it disorders of affection. First, for the first time, coining the term affect. So, Philip Pinel started mental asylums in which humane treatment was done for the mentally ill. And when he documented these cases, serial documentation was done for these particular cases of mood disorders. He found out that in 1700s, for the first time, he found that the prognosis was significantly different for some people with disorganized behavior and other people with disorganized behavior. And he separated people for the first time, people with affective disorders and people with the negative symptoms, schizophrenia, or with other psychotic people. The standards of general health and nutrition would improve in the 19th century, and in these mental asylums, Pinel found out that he discovered that people with affective disorders could even be discharged from the asylum after psychotherapy, after some therapies. So there he differentiated these two illnesses. In 1866 and to 1950, Adolf Meyer for the first time coined the term psychobiology to emphasize both psychological and biological factors. He used the term depression for the first time. This is where we after this time we stopped using the word melancholia. So we still sometimes use, but the diagnosis the word for diagnosing it, the word has changed to depression. So he told that there are psychological factors and then there are biological factors also, and both of them cause depression. Later on, Sigmund Freud, he gave the aggression turned inward model. What he theorized was that the depressed effect is derived from the retroflexion of aggressive impulses directed against an ambivalently loved internalized object. What he meant was there was an object that was intensely loved by a person, and he internalized that object, and the depressive effect that he is having is actually an aggression towards that internalized loved object. That is why a person starts having low mood and decreased self-esteem, negative ideas, because he is having aggression towards that internalized object that is intensely loved. So that what he said, this is a quote, that in an attempt to prevent traumatic loss, the object had already been internalized. The patient then became a target of his or her own thanatotic impulses. The person is targeting himself again and again. So narcissist vulnerability and low self-esteem, the person is already vulnerable. There is perceived rejection, anger at others, but that guilt and self-directed anger then again lead to this vicious cycle. And the people who are stuck in this vicious cycle then move on to depression. So object loss, Sigmund Freud also gave an object loss and theory of object loss and depression. And object loss refers to traumatic separation from a significant object of attachment. So the severity of depression depends upon the symbolic meaning that object may have for that person, not any arbitrary way that we could assess objectively the subjective meaning that person has for that object. So this was a two-step hypothesis. So what he said was that in childhood we are attached with certain objects, we lose those objects, and then we are predisposed to depression. In later adulthood, whenever there is separation from and for any other reason, then the predisposition that we have had since childhood that again develops and then leads to full clinical depression. So two steps are there. First, separation in childhood that predisposes, and then again in adulthood that leads to full-fledged syndrome. So, loss of self-esteem may result from symbolic losses involving power, status, roles, identity, values, purpose for existence. Low self-esteem was what Sigmund Freud said was low self-esteem was a trait that was a part of depressive personality, and such people had a higher risk of sinking into depression in the face of an environmental adversity. So when even in the ICD-10 criteria, we talk about low self-esteem as a symptom, but Sigmund Freud said that it was already a part of whoever's personality it was already a part of, that person was at an increased risk of depression. Aaron Beck gave the cognitive model for depression. He said that thinking along negative lines was a hallmark of depression. He redefined aggression in terms of cognitive trait, feeling of helplessness, hopelessness. So he said that people with cognitive impairment interpret most events unfavorably in context with themselves. He also gave the cognitive therapy. We'll talk about that later. The psychotherapies. He was also first time he said that hopelessness could lead to suicidal ideation. Later on, he developed a learned helplessness model that he proposed that the depressive posture is learned from past situation in which the person was unable to understand, terminate undesirable contingencies. Past events might shape a characteristic cluster consists of passivity, lack of hostility, self-blame. For example, in an experiment, dogs were given electric shocks repeatedly. But dog was not allowed to escape from that chamber. Later on, the dog developed feeling of helplessness that I will not be able to escape from that chamber. So that is his past experience that he will not be able to escape, and it is his fate to get an electric shock. That even later when the chamber was open, he was able to escape. He would still be afraid, having low mood, that shock तो ये दे ही देंगे मुझे, like मेरा कुछ नहीं हो सकता. So this is what he proposed. And even in human beings, there are past experiences in which they were helpless. Even now, when they are able to change the situation, they still blame themselves. Lack of hostility and self-blame due to past experiences. So, after giving the cognitive model, Aaron Beck proposes the first psychotherapy for cognitive improvement known as cognitive therapy, CT. This form of therapy focuses on identifying negatively balanced automatic thoughts associated with depressive mood and use strategies to both test the accuracy of negative thoughts and consider more rational alternatives. He would tell the person to list out the negative depressing thoughts. He would then challenge the accuracy of those thoughts, the low self-esteem, that and the ideas of helplessness, and tell them that not truly helpless. And then he would consider more rational alternatives to those thoughts, some better alternatives that could replace those particular negative thoughts that person is having. This was cognitive therapy given by Aaron Beck. After these psychological theories, we began developing biological theories. In the 20th century, the complex physiology of limbic diencephalic centers could not be understood due to a lack of technology, but most of it was learned from animal work. So norepinephrine containing neurons are involved in many functions, including mood, arousal, appetite, rewards, drives. So we knew that when norepinephrine was involved in all these things, and all these things are disturbed in depression. So there must be some relation of norepinephrine to these symptoms. So Raymond M. Kwok gave the in the 20th century, he what he theorized was that serotonin and norepinephrine, when they were both in a normal amount, they could the person was normal, euthymic. In retarded depression, with the more negative symptoms and more cognitive declines, the person there was and decrease in the limbic norepinephrine activity. In agitated depression, there was a decrease in the serotonergic activity. the evidence was there was no technology to know to isolate serotonin or to test any imaging. But what we had was evidence in other forms. So risperidone was a drug used for hypertension, and it acted by depleting biogenic amine stores. And what they found out after giving this drug was that the side effects were very similar to clinical depression, the cognitive decline, the low mood. So this was known as pharmacological bridge. They found evidence from mechanism of action of one drug and used it on another drug. Similar, we later on read that TCS were also discovered in a similar way. Antidepressant medication, which elevate clinical depression. Then they found out when they found out that this particular medication, risperidone, decreases biogenic amines and causes symptoms of depression. So they started discovering, they started to find out any medication that would increase the level of biogenic amines that would help us treat depression. They found out that three major amines were involved: serotonin, norepinephrine, dopamine in this whole pathology of depression. So they give the permissive biogenic amine hypothesis. The permissive biogenic amine hypothesis means serotonin deficits permit the expression of catecholamine-mediated depressive or manic states. Was what they said was an intact serotonin system was necessary for optimal functioning of noradrenergic neurons. So catecholamines, norepinephrine, they had been getting the cognitive symptoms of depression. Serotonin was necessary for optimal functioning. A decrease in serotonin would lead to malfunctioning of the catecholamines and norepinephrine that led to symptoms. So what they tried to do was they tried omission of tryptophan from the diet. Tryptophan is a precursor to serotonin. Tryptophan from the diet of antidepressant responsive depressive patient to find out if it annulled the efficacy of the antidepressant. So this diet also induced the EEG changes of clinical depression and the sleep changes that were associated with clinical depression. But it could not be again repeated with increasing the amount of serotonin. So William McKinney and Hagop Akiskel in 1973 developed a conceptual framework that considered affective syndromes as a final common path of various psychological and biological processes. So what they said was that we can't find one theory. Monoamine theory causes depression, or psychological theory causes depression. They said there are multiple phenomena. So they gave this graph which starts right from the early loss, the heredity, and the gender. So what they said was a loss in the childhood, some hereditary factors, and a particular gender were already predisposed and they had an affective temperament. Then once, if that person developed a stressor or the person affected temperament can already lead to a limbic diencephalonic dysfunction, and that later on led to an affective episode. The affective episode could lead to further stressors, and then again the person might be stuck in this vicious cycle. So multiple factors at this time they theorize multiple factors: early loss, hereditary, gender, and stressors also. So we have evidence that evidence that said heredity is involved in bipolar and recurrent major depressive disorders. The depressive inheritance might translate into impaired coping under stress, and bipolar inheritance might translate into cyclothymia. It is not necessary person with bipolar parents might develop this bipolar disorder. Might lead to cyclothymia, may even lead to changes in circadian rhythm. Some affective symptoms may not lead to full-fledged bipolar. So chromosome 18q was 18q has been labeled as the culprit chromosome in this. The genetic mechanism of mood activity in panic appears to be subversed by chromosome 18. We see in chromosome 18q deletion syndrome. The people develop among other symptoms. They also develop symptoms of mood disorders such as anxiety, irritability, and depression, and they sometimes are also on the autism spectrum disorder. So that has implicated chromosome 18q. So there is always a developmental predisposition. We see that, but there is a criticism for this theory that there is already, we already know there is a genetic component. So people with mood disorders, they are in conflict, they lead to separation, divorce. So that might further aggravate and lead to developmental predisposition to the person. So people with, let's say, depressed parents, person with depressed parents, later on in his early life, he will have to face the symptoms that they are having. There will be conflicts, interpersonal conflicts in the house, and that again leads to um, developmental abnormalities that increases possibility of developing depression in adulthood. So we know that monozygotic twins they are this kind of a full-blown mood disorder. So one monozygotic twin, among two monozygotic twins, there is a significant evidence of having the similar temperament for developing mood disorders. And such temperaments have also been discovered with bipolar 1 disorder, that both of them are genetically linked. So most individuals, they do not develop clinical depression when they're exposed to environmental adversity. So we know that there are some people with intense temperaments that are predisposed. Only they can, and they are more predisposed. So even with a minor life event, not as significant, they will develop depression. So Dr. Arvid Carlson was a pharmacologist. He won Nobel Prize in 2000 for his contribution on neurotransmitter dopamine. He was among the first researchers who developed the first SSRI compound zimeldine. It was later taken off the market because it led to Guillain-Barré syndrome, but mm, uh, he was significant in the discovery of SSRIs. So in 1940s, while developing the anti-tubercular drug isoniazid, the researchers found out what they said was a better alternative for isoniazid, iproniazid, and it started treating it for tuberculosis. They discovered that in people with tuberculosis, a person having a chronic illness, at that time it was considered a fatal illness. People with tuberculosis, they also had mood symptoms. So when they started giving iproniazid to people with tuberculosis, the mood symptoms also improved. The person had euphoria, psychostimulation, increased appetite, and improved sleep. So that is when it was discovered that the uh, MAO inhibiting, the monoamine oxidase inhibiting activity of this particular drug could also lead to antidepressant effects. So the monoamine oxidase is an enzyme that breaks down serotonin, dopamine, epinephrine. So MAO inhibitors stop that breakdown, and in turn increase the levels of these monoamines. So more MAO inhibitors were later on discovered, and they were widely used in treatment of depression. And by 1959, imipramine was used, which was widely used for treatment of depression. It led to an antagonism of adrenergic, muscarinic, and histaminergic receptors. So it led to many side effects, dizziness, memory impairments, and drowsiness, but it was still considered better than MAO inhibitors at that time. By 1987, fluoxetine was developed, the first SSRI, which increased the activity at the postsynaptic serotonin receptor produced by SSRI. So what SSRI is doing, it is inhibiting the reuptake of serotonin. So the level increase at the postsynaptic receptor. So SSRIs, we know the example, fluoxetine, fluoxamine, paroxetine, but they have significant side effects. There are many sexual side effects. So the search was still on to find a better drug. So by 1989, they discovered to decrease the sexual side effect, bupropion. So bupropion had a very low risk for sexual side effects, and nearly half as compared to the tricyclic antidepressant, the MAO inhibitor SSRIs that were used at that time. Is primarily a dopamine norepinephrine reuptake inhibitor, not much effect at the serotonin. It does not have much effect on the serotonin. So serotonin non-epinephrine reuptake inhibitors were introduced later on in 1993. SNRIs are similar to TCS. The inhibitor reuptake of serotonin norepinephrine. So venlafaxine and desvenlafaxine, we know the examples, still use them widely. So by 2013, in an attempt to find a even better drug, vortioxetine was approved by the FDA. It belongs to the piperazine chemical class and high affinity for serotonin receptor. So this acts as a, instead of reuptake inhibitor or any enzyme inhibitor, it acts more as a serotonin agonist, directly affects serotonin receptor. So, but it is still nausea and headaches are a side effect. The glutaminergic dysfunction was discovered for MDD. So clinical studies have by 1993 and 2000 said that a glutaminergic hypothesis for major depression, that in in plasma and cerebrospinal fluid concentration of glutamine, there was a difference in the depressed patients and the non-depressed patients. So based on this hypothesis, ketamine was used as a drug for treating depression. Ketamine in the 1970s was used for the first time in the Vietnam War as an anesthetic and as an anesthetic for injured soldiers to quickly alleviate pain and try to get them back to the war field. But people in during the Vietnam War also discovered hallucinogenic effects for ketamine, and when they brought it back to America, they discovered not only it had anesthetic properties but also a lot of addictive effect. So at that time, it also developed a reputation for being a party drug and an addictive drug. So for a lot of time, no research was done on ketamine for purpose of depression. But a single sub-anesthetic dose 0.5 mg per kg intravenously infused over 40 minutes has a significant antidepressant effect. And the biggest difference between ketamine and the other oral antidepressants that we are using is that they take some time, at least a 4-week, 12-week delay. But ketamine will immediately elevate depression right im- immediately when it is transfused. Similar, their oral ketamine formulations, IM ketamine formulations have not produced a similar effect. So intravenous ketamine infused over 40 minutes repeatedly for the first few days has a much better efficacy. This therapy may not be able to replace like oral antidepressants immediately, but it still is a possibility that it can replace ECTs for severe depression, because many times people are still have a stigma against ECT. So intravenous ketamine therapy can be used there. So the research is still going on in RTMS for depression, but it is found it has significantly improved depression 58% of patients and provide complete remission by 37% of patients. But there are still very limited studies, and the major difference has been found only at the 2-week follow-up window. Later on, after 2-week follow-up window, there was still no significant changes in the control and the active groups. So thank you. The reference is mainly from the Oxford textbook and an article about the history of antidepressant drugs, with the historical part mainly from the CTP.
So the floor is open for questions, comments, and live discussion. Any queries?
What they tried to do was they at that time they did not have any technology to uh, any to find out one single to either isolate serotonin or to look at serotonin, find serotonin biologically. So, but what they knew from theoretical part of tryptophan was a precursor that later on led to the then later on developed serotonin in the body. So they in patients, antidepressant responsive depressed patients, they developed an antidepressant. When antidepressant दिया, the theory was that it increased serotonin levels. They then omitted tryptophan from the diet. What they said was अगर अभी depression develop होती है, then it is serotonin that is causing depression. So that was relatively successful in EEGs, but with L-tryptophan they could not repeat the same results.
So anyone can summarize the presentation, whole presentation in few lines. After your summary of the presentation. Brief sir. Yes, Dr. Ayushi.
Years, thousands of back, the term melancholia, and how melancholia, then that book which was written, The Anatomy of Melancholia, then it came on to how the word affect came into being, then how depression came into being. After that, he went into various stories of depression. First of all, he went into the psychological stories of depression, followed by some of the biological theories of depression. Then he went on to the antidepressants. That's how the antidepressants came into being, what were the side effects of the previous antidepressants, so newer antidepressants came into. And then he went on to newer generation, like the newer things like neuromodulation and all that.
Questions? You could understand, you have put this world. A lot of new faces today. Depression is something which is, he explained depression. Yes, please.
In terms of psychology, I like first because I was not able to. He said that it's hereditary factors, like more, like if someone has hereditary factors, is it more possible that they'll have depression even at a minor incident,
Yes, it is possible.
or if like someone does not have hereditary factors, but they have been through very traumatic events. So will it play a role then also, or like the person can still develop depression?
So anyone can develop depression. No one is like immune to depression. Everyone has a possibility. But a person who has some genetic predisposition or any other temperamental predisposition, he is more likely to develop at minor life events, minor stressful events. Person who does not have any predisposition, either temperamental or any personality or any hereditary predisposition, he might need more stressful life events to develop depression.
A very good question. She is asking more intensity of hits required to manifest depression. So it's like two hits. One is the vulnerability. In childhood, you can have genetic vulnerability, you can have an early childhood trauma. Second, it can be an precipitating event like a financial loss or a breakup or a marital or loss of spouse. So you might have first hit, you might have second hit, you might not have both the hits, you might have both. So someone with no predisposition, nothing, no triggers might also develop depression. But still, the broad thing is anything developing before 40 is genetic. And anything developing which develops after 60 is basically neurodegenerative. So it is more in between this age span, it is mixed. So, but you have to have that vulnerability. Might not be that you might get it in families. But this is very, you have to be very clear. So anyone, as I said, anyone in any circumstances can go into depression. But we have to find out. So a Kiskal model explains many of the things clearly. You can go to the model. Any other question? You have 3 minutes. Dr. Sanjeev is waiting for the round. She has a video.
Parents are responsible for what is the reason?
So you're saying if any monozygotic twins, Mankam,
The whole purpose of doing a study with twins is that अगर एक twin को कोई particular इंसान दोनों में अगर कोई similarity मिलती है, so we know that they for monozygotic they share the exact same genes, they share the they have the exact same genetic code, the same parents, same zygote was there. So अगर दोनों में same later on in adulthood same disease develop होता है, we know that it is due to genetic factors.
And you get different families, then they develop a disease. So it is like it is nature, not nurture.
so the question is clear. And it is answered.
What will be the difference in the zygote is not in the case of zygote. It's a different case.
See, the twins हैं तो genetic material ज़्यादा share कर रहे हैं. Rather कि अगर कोई first degree relative है या कोई brother sister, तो उनमें chances of कोई illness build up होने के तो genetic explanation ज़्यादा हो. तो आप अगर दोनों में depression हो रहा है, तो आप ये देखेंगे कि वो genetically possible ज़्यादा है. But उसमें environment भी common है. तो अभी कैसे कहेंगे कि environment का ज़्यादा role है या parental एटमोसफियर का ज्यादा रोल है या जीन्स का ज्यादा रोल. तो ऐसे में वो क्या करते हैं, डॉक्टर सजीव ने बताया कि उनको अलग अलग रियर फैमिलीज में रियर किया जाता है और उनको कंपेयर किया जाता है उन ट्विंस के साथ जो सेम फैमिली में रियर. तो वहां पे एनवायरमेंट न्यूक्लियस कर दिया, फिर वो प्योर जेनेटिक. अगेन ये सब एक स्टडीज कोई अभी अभी इंटरेस्टिंगली वी स्टिल डोंट नो, वी आर नॉट वेरी श्योर व्हाई डिप्रेशन. All these are hypothetical level. If you summarize the whole presentation, we started with bile. We then went to psychological theories, psychodynamic theories, neo-Freudians, biological interpretations. Then I think we wanted to come to networks, connectomes, and then various therapies related to it. So that becomes a complete evolution of depression. I think evolution of depression should be the right seminar. So that says it is interesting, but we still don't know, particularly ki, okay, here the fault lies in depression. It's a very heterogeneous entity. So depression also have a lot of facets. Like one time you can explain various types of depression.
Depression, when
So depression both types के हैं.
types we can't classify into types. Like this is one type, this is another type. It acts as a whole spectrum. The mood disorders, the whole effect occurs in the whole. The mood disorders occur in the whole spectrum, right from a person with two extreme ends, depression with completely negative symptoms for full cognitive decline, to a person with full-fledged mania. The whole spectrum exists. Person with any predisposition to any bipolarity either could develop a could range bipolar depression, which ranges from to both extremes, to mania or hypomania to depression. A person with cyclothymia might make us switch much quickly, but the severity of a particular affective episode may not be as severe as a person with bipolar. But a person can develop recurrent depression. It will always be depression, but recurrently, it will always go into depression. It will not go into mania, hypomania, but it will be recurrent. Just like a bipolar episodic and recurrent, or a person can develop a major depression, which can be unipolar and persistent for some time. Other reasons could be there. There could be organic reasons, vascular depression, mostly seen in old age.
Yes, basically the whole point is we need to say that a lot of people have explained depression in a lot of other adjectives: vascular depression, melancholic depression, atypical depression, irritable depression, smiling depression, mass depression. So there are a lot of because this is not a very commonly okay. This is depression. The depression can be differently expressed in different individuals, differently expressed in same individual at different times. So that is why someone who is interested in reading all these things, you can actually contact us and then we can provide you the details. Any other questions? Dr. Simran, comments? Dr. Sanjeevani?
Because the flow was there. So what I found is interesting is regarding science, एक तो AD में है, ऊपर से उसके बाद सीधा 1600 मीटर और 1500 साल सब dark में थे, dark pages of
1800s, some kind of technology they started developing.
Yeah.
Lighting methods came into play. Yes.
और जब आपने ketamine का बोला, even Elon Musk takes ketamine, like there was so he is like he feels much better.
Not sure that he's bringing up some pharmaceutical agents. He's- But actually, ketamine and everything, they are euphoric agents. So antidepressant, this is actually something which is pharmaceutically built up. They're actually euphoric agents. They'll give you some euphoria. Other than that, sustained effects, long-term complications, we still don't know. That is why you never see it becoming first line or second line.
Mainly for the first
Something which acts so quickly can also have its own. So it is like an euphoric agent with substance intake people might use.
So this study was mainly to get the FDA approval for the first 4 weeks. जब तक SSRI effect builds up for the first 4 weeks.
So I think Dr. Mankaran presented well, but background needs to be worked upon. This is for everyone. I didn't point it out specifically yesterday to Mankaran, but I want everyone to listen to it. That if you have a very lightened background, very high lit background, so the slide should be white and the written material should be in black. If you have अच्छा, projector is खराब. So छोड़ दो. And if it is in dark background, so the background should be dark and the font, then written material should be in the light. And even a very good presentation, the last day or the day of presentation in the morning, you should write an outline and take home message. So then it becomes a complete kind of a presentation. He worked very well. Very difficult seminar to conceptualize, needs a lot of reading, lot of boring material and a lot of material, the past, those spiritual, those exorcisms, everything must have come into his knowledge. He has managed to, give it an streamline, managed to streamline this presentation. But it is very, very important. Any disorders, you need to know the history. So first time who used the word depression, first time who used the word epic, melancholia was given by whom. All these are Viva questions. Who gave the model of learned helplessness, depression theories, monoaminergic hypothesis of depression, Nobel Prize won. So these are Viva questions. So if you struggle in exams, you do well in Viva. So examiner will also think because of anxiety, you couldn't perform well in your long. So anywhere you might get the benefit. So these seminars are fulfilling that. So read and come out. So with this, we close the presentation. I think when we have case conference, 12:30 we have case conference. All of the students are invited. For I think this will be your first case conference. So who is the presenter? So Dr. Abhishek will be presenting it, and I think we'll see to it how a psychiatric case is presented in detail. What we do here in rounds is very brief. So please attend this. The case conference. Thank you.